Welcome to the fourth talk on internal disc disruption, possible identification and possible healing. If you have watched the previous videos on IDD, you should have a reasonable understanding of this condition. It is very exciting to reach the point where I may be of some help to IDD sufferers. The best way for me to explain, I think, is to go through the process I would with a new patient. I would listen to the explanation of what the patient has been going through. I would look at x-rays and MRI. I would do a physical exam and various tests to try and work out what the problem or condition is. If this leads me to what I think is IDD, I would follow a certain process. So let's make up an IDD patient. Patient has been to a medical doctor, physiotherapist, chiropractor, with no significant help. The only relief is from medication, but that's of a temporary nature. Let's say the pain is in the left lower back. I will go through the 9 steps of the Delphi study. I may find the patient has pain with extension, left lateral flexion to the side of pain, and not so bad to the other side. I will ask the patient to sit, do a seated straight leg raise, but on their involved side it will be stiffer or they might not be able to straighten the leg. Still seated, I'll ask the patient to cough or sneeze, causing some pain. But if I ask the patient to hang, lean and cough, it is less pain because there is less pressure on the disc. I will have the patient lie down. This is typically not comfortable, but bending the knees or putting something underneath decreases disc pressure, more comfort for the patient. I will now do a straight leg raise. And typically, on the left or involved side, it is stiffer and does not go as high. Next, I will have the patient lie on their stomach. I will do flexion, which creates a bit of pain in the lower back in most cases, but if I put blocks in and bring up the legs, it is often more comfortable as pressure has been released on the disc. I will then press on the hamstrings, and typically on the left side is sensitive to touch. My treatment of choice is distraction with flexion. We distract and flex. Distract, flex. Distract, flex, to decompress the disc and centralize the nucleus. Although this is a safe method, in my opinion, I would advise you get somebody who's competent and experienced to do this for you. If it's done too soon or too vigorously, you might make the tear worse. I will do flexion distraction or distraction with flexion a few times, carefully watching for any signs to stop and asking the patient continually how it feels and stopping immediately if there's pain. At the end of doing this a few times, I would then press down the back of the leg, and typically the tenderness on that left side has somewhat eased or gone away completely. I will redo the straight leg raise. And on the left or involved side, typically straight leg raise will be better, higher, and less discomfort for the patient. I would explain that X-ray, MRI are inadequate at diagnosing IDD. Only a discogram can conclusively prove the presence of IDD, but it comes at a financial cost, often involving pain and risk. Look at my video 2. I would go through how disc pressure was decreased. Coughing when leaning, less pain. Lying on back with legs up or bent knees is more comfortable. When lying on your stomach, blocks give relief. With distraction work, there is less hamstring pain and increased straight leg raise. I would then explain how IDD works. I would advise they look at video 1. I would explain to the patient how, in my opinion, they may have the early stages of IDD, perhaps a grade 2 or 3. I would further explain that I want them to improve back to a grade 0 and not aggravate towards a grade 5. So how do we heal IDD? My chiropractic management and home advice are always the same. Decrease disc pressure and allow the nucleus to centralize. Why go to all this trouble? We need to allow osmosis to function. This will allow microscopic cleaning and healing. The fissure or tear will slowly close. I will explain disc pressure using a chart from this book. The chart shows relative change in pressure on L3 in various positions. This is not an IDD sufferer, but just gives the patient an idea of pressure changes in different positions. Twisting, lifting, excessive sitting, etc. will just reopen the tear. The patient is expected to follow a low pressure lifestyle, more walking, lying down and leaning. I will do gentle distraction with flexion until most of the clinical signs ease or disappear. For example, there may be improvement with sneeze sign, improvement with left lateral flexion, extension, and improvement with straight leg raise. Depending on the severity of the IDD, this may take a few days or even a few weeks. Healing is different for everyone. As the patient improves, management will include soft tissue work, stretching, exercise, and chiropractic adjustment with an instrument to mobilize the facet joints without compressing or twisting the disc. Many patients don't heal completely, but are satisfied by understanding their condition and knowing the pain is not imagined. Patients feel empowered by knowing how to deal with IDD. In summary, we are trying to decrease disc pressure, centralize nucleus, and encourage osmosis. The fissure or tear will slowly retract away from the sinovertebral nerve, where it has been causing chemical and mechanical inflammation and pain. If the patient's signs and symptoms improve, we may agree on the diagnosis of internal disc disruption without the definitive discogram. What saddens me is that great medical research in the past gave us knowledge about the most common cause of back pain, and sadly, we ignored them. Thank you for listening to the 4th talk. I will do one more talk to conclude the lumbar series.